Your GLP-1's low risk. Insulin, high risk. Your weight gain. So again, if they act on insulin, they're going to cause. So your sulfonylureas are high, TZDs are high because they work on those nuclear receptors that affect glucose transport into the cell. And then insulin. Side effects. So we saw lots of side effects with TZDs, a lot of side effects with the SGLT2s. The others are fairly low. DPP-4, very rare, fairly mild drug. With the GLP-1s, we're going to see GI is the highest, with hypoglycemia with insulin, and hypoglycemia with sulfonylureas. So that's what you do. You're looking at the patient. So there really isn't a study that said the best thing to do next is this. There isn't. You have to know the drugs and you have to look at what is best for the patient. Usually I would have a couple in mind. I would talk to the patient and I'd talk a lot about when do you eat? What do you eat? When do you work? I think about what's going to work best for you. Then I would lay out, say, here's some options. And here's what each of these options will buy you. And here's what it would take. And then I would let them choose if they would choose. Now sometimes patients go, I don't know, you choose. It would be like me going into an investment banker, listening to all this and it going, it's like, you choose. So I get it. I just have to think about that and I get what how overwhelmed they are. So usually if they say that, then I'll say, here's what I think is the best way to go. And if they go, yep, that's what I want to do, that's what we'll start off doing. Triple therapy, it's the same thing. You've got 2 drugs on board now. I can tell you that if you are above 8% with 2 drugs, it is hard to get them down below 8% with just adding another drug. Because you don't have that many that are that powerful. If you've already used a sulfonylurea and metformin, you don't have another one that will do it. Now, that being said, the caveat I put in there was if all you do is add a drug, if there isn't anything else that goes along with it, if they don't do something different with exercise or weight or what they choose to eat, then the drug itself will not do it. I have some stories to tell you about patients who really taught me a lot. Often I would have patients sent to me who the physician was like, there's nothing else I know how to do, you need to go on insulin, go see these people. Sometimes I wonder how much they emphasize, I want you to start on insulin, because usually when they get there, the first thing the patient would go is, I'm not going on insulin. So I had this lady, she was an older German lady, she was very stout, she wasn't that fat, she was just a big woman, short little woman, came in, she was 12%, A1C, and I said, I got smart over the years. I would say, your doctor has referred you here. Can you tell me what you understand that he has referred you here? Because I quit saying, your doctor sent you here to start on insulin, because that didn't go well usually. So she did know that, but she told me, she said, I don't want to go on insulin. So I usually would spend a lot of time talking to them about where they were and at what point and what the likelihood and why it was important to get down to a certain level. If you continue on this pathway, here's what's likely to happen. Here are some options, but where you sit right now, insulin really is the best drug. And she said, I don't want to do it. After probably a 30-minute going back and forth and listening to her, she said, what would it take? And I said, well, what it would take is you would have to move more, you would have to exercise, you would have to lose some weight, and you would have to change the foods some of the foods that you eat. And I said, but I do not believe you can get down to goal with that. I said, I'll just tell you, I just don't think it will happen. And she said, well, I want to try it. I said, okay, I'm good with that, but we're going to set, I don't remember exactly, 6 weeks, 8 weeks, and when you come back, we'll see how that's working. So she went out, I thought there's no way. She came back, and her A1C was 8%. I said, what did you do? And she said, well, And she did have bad knees. That's why I thought you'll never be able to move enough, because she and her brother, who were about the same age, in the same shape, had bad knees. It would take them an hour to walk 2 miles. But they did. They started walking more. They were already walking. And they walked enough that, and cut out enough of the carbs that they were eating, that she was able to do it. It taught me a lot. She wasn't the only one. I had another guy who worked at Tinker, very smart guy, very big. He was probably 6'3", 6'4", and he weighed over 300 pounds, but he was just big from top to bottom. I mean, if I looked at him, I would never have said he weighed that much. He was just a big man. And he sat down, and he was also 12%. His doctor had sent him for insulin. He said, I'm not going on insulin. I said, okay. He said, and I'm not going on a diet. I said, well, okay. I said, why won't you go on a diet? He said, because I've done that in the past. I've lost a lot of weight, and I always regain it. So he said, I'm never going on a diet again. I said, okay. He said, and I don't want to take drugs. So I said, okay. He said, so what do I need to do? I said, well, you're going to have to, if you won't go on a diet, you've got to adjust some of the things that you eat. And I need you to move. Well, I don't like to exercise. I'm like, well, okay, you have tied my hands. There is nothing I can do. So I usually put it back on them. Well, then what do you want me to do? I have no wand. I have nothing. Your body doesn't care whether you do this or not. Diabetes marches on. Just because you don't want to do anything, the diabetes is going to give up, go, okay, let's go home. It just marches on down its path. So we had our discussion. We had our plan that he would do 3 days a week. He would walk. I said, okay. So we set up a time for him to come back, and he agreed that if that didn't happen, we would talk about a drug ban. I told him about metformin, and he was like, okay, I'll think about it. So he went away, he came back, and he came back at about 6%. I said, what did you do? He goes, well, I started walking he worked at night at Tinker, and they have some type of gym or lap thing he could do. He goes, and I got to where I really liked it. And he was a real science guy, so he had these spreadsheets. He would overwhelm me with data. And he had just started keeping track, and he would see, man, if I did this, it went on down further. And he ended losing about maybe 10 to 15 pounds, and he pretty much maintained that. And he changed to much more protein, like nuts and proteins. And lo and behold, so it taught me, you don't have to lose weight, but man, if you'll walk and choose different foods. And he was able to maintain that for most of the years that I saw him. He eventually did go on metformin, and that was about it. It was incredible. Then I had an old lady come. She was 73 years old. She sat down. Same doctor who always sent the insulin starts to me. I said, okay, so I understand you're here to start insulin. She goes, I'm not taking insulin. And the more I listened to her, I thought, you probably shouldn't be on insulin. Live by herself. She was a little bit daffy, but she was fun. She was an old school teacher. She was a hoot. But she was a little bit kind of not real steady on her feet, and she was like, what do I have to do? Because I don't want to go on insulin. I'm like, well, you're going to have to move, and you need to quit eating all that mac and cheese and potatoes that you like and snacking all night. She wasn't very big. She was probably 150 pounds. She was about 5'6", but she carried it all kind of in her midsection. So she went away. She was 9%. She came back, and lo and behold, she was 7.3%. I'm like, what did you do? She said, well, I did what you said. I quit eating potatoes. I quit eating, most of the time they don't do what you say. And she said, and I had this little garden in the back, and so I just followed a little path. My son built me a rail so that I could, go out there. And this was in the fall. This was like in the winter. I was just shocked. So it just told me, I'm telling you, most of the time, what's wrong with their diet, with their diabetes, is what they eat, and they don't move. So those patients, those are just 3 out of many that taught me a lot about what patients can do and how much things will pay off if they will institute them and do them. And people usually get pretty motivated when it comes to either having to start a drug or start insulin. Those are the two times where you usually can get a lot of mileage out of them. Okay. So I told you that because if you are 8%, most of the drugs cannot get you to the goal of 7%. So I'm always looking at, if I set my goal for you at less than 7% or even less than 7.5%, do these drugs have the power to get you there? If you're at 8% and you're already on 2 or 3 drugs, most of the drugs will not get you there. Insulin will do it. So usually adding a basal insulin is a good way to go. Sometimes the SGLT1s will help, and I'll tell you some stories about patients that I've used that drug in. So now we're to the injectables. So these are the bigger powerhouses, but patients often don't like to inject themselves, so it becomes usually not a first line. People usually don't want to jump on it first line. Okay, so we'll start with the GLP-1s. So these are the drugs that are analogs to the incretins that you produce. So we like these drugs because they do what? Our GLP-1s do what? So they are produced where? In the gut by what cells? L cells, and they secrete their incretins in response to food coming into the gut, and they send a message to 2 places, to the brain telling it satiety, and then the second target is beta cell. Beta cell, and it tells the beta cell to do what? Release insulin related to the glucose level in the blood. Okay, so on page 2, there's quite a few of them. Anytime you see quite a few, it tells you there's quite a market for them. If you go down the list, you can see some different things. Byetta was the first one. This is the one, if you ever said the Gila monster, where they took exhibit from the saliva of the Gila monster. They figured out that it would lower blood sugar. Well, Byetta came off of that. So it was the very first one, and then Victoza down the. Victoza was better because it became once a day, whereas Byetta was a twice a day. Then they started figuring out you could give these things once a week and they still work. So then Bydureon came out. It was a once a week Byetta. Then Tanzium, Trulicity came out. They were the next 2, and then the most recent one is the Ozempic or semaglutide. And it's a weekly. So you see you have twice daily. The reason I put Byetta on there and still talk about it is that insurances will often, that's where they want you to start. These things are expensive. They're about $300 or more to start. Last time I tried to get somebody on Victoza, it was $600, but that was about 30 years ago. So because they're so expensive, they usually push you to Byetta first. I don't care, that they work, but you have to use them twice a day, and you have to use it in accordance with a meal, like 1 hour before a meal. So it's a little bit more particular in how you use it. You'll see that some of them need to be mixed, some of them before you use them, and some of them are ready to go. Some of them you have to get started, and then you have to wait for, I don't like Tanzium because you have to wait. Then, some of them are approved to use with basal insulin. These drugs are great, using them with like Elantis and Bydureon. I've had really good luck with them. I like Trulicity a lot. I like its dosage form. I like its pen. Victoza is great. It works as well. They all come as pens. Patient either dials a dose or the pen is specific for it. It'll be a month's worth usually, except for Victoza. And they all start at low doses because these drugs are really hard on the GI tract. I would say it was 50-50 whether I could get a person to tolerate it or not. They really make people sick. So starting at that low dose, titrating dose up about every month usually works. The people who can tolerate it can have fantastic results on it. Contraindications, type 1 and ketoacidosis. I'll tell you that there's lots of research going on looking at them for type 1s, but right now they would not be something to use. Almost all of them are hard on the GI tract. You would be an evil person to put somebody who has diarrhea and already has stomach problems on these. They really would aggravate it. Pancreatitis is a very severe adverse effect or serious adverse effect that can occur with these drugs. It can be a necrotizing hemorrhagic, which means they die, usually. So if people have got a history of pancreatitis, do not use these drugs. With Byetta, renal impairment, I think it's the only one that requires adjustment in renal insufficiency. Here is a big one. With the next one, it first came out with Victoza, but it is a class effect. Do not forget it. You should avoid these drugs in patients who have a history or a family history of medullary thyroid cancer. If they tell you they have MEN2s, they'll know. They'll tell you that. A lot of people get them as kids, so they know. Because these drugs can worsen those, the C-cell cancers in the thyroid. So that's one of the first things I ask patients, if that's what I'm thinking. Any history of thyroid cancer in your family? Cardiovascular benefit, liraglutide has the best data. If I was going to use a drug because of cardiovascular after metformin, it would be liraglutide. That's my opinion. It decreased cardiovascular death from all cause, from cardiovascular cause, and cardiovascular events. Just giving you an example of if you were going to prescribe it with Byetta, you start with the 5 micrograms and you have them take it within an hour before like breakfast and supper, 2 meals a day. This drug has some unique drug interactions. It slows down GI transit. So if you have drugs that are dependent on getting through the gut to be absorbed, like antibiotics or thyroid, this drug will interfere with that. So spacing, taking the drug before and several hours, becomes a little bit of a dosing juggle. Is a problem. Victoza is once a day. You can give it any time of the day. Doesn't matter when they eat. But Byetta has to be with before that meal. And then Bydureon is once a week, so you would prescribe it for them to take the same day every week. Maybe I didn't do that. On the page 4 are pictures of the different ones so that you can see what I'm talking about when I'm talking about a pen. They all have needles, pen needles that have to come with them. Some of them you have to prescribe that separately. So I had you do that on your prescriptions. So don't forget that, because if you just write for the pen, the pharmacy's just going to get the pen. So you have to buy them separately and prescribe them separately. I'm going to show you pens in a little bit, so if you've never dealt with them, I'll kind of orient you to just all pens. You'll see that with Bydureon, it comes as a vial and a lyophilized powder, which means a diluent has to be added and dissolved, and then they withdraw it, and then they give it. That's why people have moved a little bit away from Bydureon, and why Ozempic probably has a chance is because you can get around that having to mix. But Bydureon also got smart in that they came out with a pen as well. So they have kind of both approaches. So average on page 5, average is about 1%, I would say, is what I would kind of keep in mind. Average weight loss is 4 pounds, but that it really varies in patients. The blood sugar drop in A1C is independent of weight loss. Okay, let me tell you. So I'll give you some stories that I have about GLP-1s. So just in the literature and in going to meetings and listening to people talk about these early on, these drugs tend to have a progressive weight loss. Patients continue to lose weight. They even had a group early on that they called the super losers. These were people who lost 50 and 60 pounds over like a year on them. So I always use that as a selling point. A lot of patients would choose it because they could go to, they could get that added. If you put them on insulin, they will gain weight. So I had a lady who came in. She was middle-aged, type 2. She had been on lots of different drugs. So these are patients just make me crazy. They'll come in and they've been exposed to a lot of drugs and they have a reason why they cannot take any of them. And I'm sitting there, it's like, why did you come? That's always after a while, I'm like, now why did you come? I'm not sure, because you seem to have decided all these things, so I'm not sure what you want me to do. So we talked about a few things as we were going along, and her A1C was over 11%. And after she had heard the different drugs and she knew about these GLP-1s, she said, that's what I want to try. And I said, well, very unlikely that it will get you to where you want to go, based on that 1%. And she was insistent. She was a very intelligent woman, very motivated, and she had left me very little options. She had been burned on metformin. There was no way I could use it. So I said, okay. So I got her samples, started her on it. I gave her a titration schedule, and I said, on liraglutide, and I said, I'll see you in a month. But if you have problems or your blood sugar continue to stay in this range, like if you have over 250 for 3 days in a row, call me and we'll talk about something else to do. So about 3 weeks after that, I get this call, or I get this note from the desk clerk that says, you've got to call this lady because she said her blood sugars were 100 and now they're 300 because she ran out of the drug and she needs some more right away. Didn't make any sense. So I called her back, and she said, on that drug, my blood sugars went to 100. I'm like, there is no freaking way they went to 100. And I said, okay. And so she told me the whole story, and I said, okay, well, I'll leave you some samples and come and get them, and then I'll see you in 1 week like we had planned. She came back, and lo and behold, her A1C was 7.4%. You can see how these stuck in my brain because I can tell you their numbers. I'm like, what did you do? And she said, well, I just wasn't hungry. She said, I'd eat until I was full, and then I just stopped. I just quit. So that satiety was big on her. And she was true. She had her meter, so she couldn't lie to me. I could go through her meter, 100s, 100, 104. Fasting, it was incredible. So that's what I'm telling you, food makes a big difference. In that area, man, I was shocked. So that was a very good. But I'll tell you, for everyone like her, I had another one who just after 1 week could not make it. Usually I could figure out in a week whether or not they could take it because their stomach and GI symptoms would be so severe that they would just say, forget it, I'm not doing this. So my experience was about 50-50, but those who could use them had great results. So I like this drug, but I've had good experiences with it. Side effects, so in the middle. Dose-dependent nausea. So that's why we usually start as low as we can, lowest dose. Weight loss is independent from the nausea. It's that early satiety. The brain just tells them you're full. Other common nausea, headache, diarrhea, and it is significant. The hemorrhagic necrotizing pancreatitis, very rare, but usually occurs early in therapy. Again, people can die from this, so don't always ask about history of pancreatitis. Hypoglycemia. These drugs cannot cause hypoglycemia on their own, but if you put them on with like a secretagogue, like a sulfonylurea, then you've got a drug that is kicking that beta cell to produce more insulin, and so will this drug, and so you can get serious side effects. So when you combine it with insulin, that's why it's been very hard for them to get approval to use with bolus insulin. But basal insulin doesn't have quite the same serious adverse effects in hypoglycemia. So be careful when you put add this to a regimen where they've already got a drug that can cause hypoglycemia. I talked about the rapid GI absorption for certain drugs with Byetta, so just remember it's just different in that whole class. On the next page is just some pictures of, to remind you the things that this drug does. The GLP-1s, they slow down gut emptying. That's why they tend to feel fuller, faster, and longer. They decrease blood glucose. They decrease glucagon secretion. Remember, that was one of the big problems in type 2, is that they have unrestrained glucagon, which just keeps telling their pancreas to put out more glucose, and they increase insulin release. It's just plus. Check. Postprandial GLP-1s levels are at the bottom. All type 2s will have a decrease in incretin production. So you see at the little top squares are the normal glucose tolerance. You've got GLP-1 production on the y-axis, and over time you've got on the x-axis. So the type 2s are that bottom line, and the middle are impaired glucose tolerance. So you see that you've got decrease in incretin production with all groups, type 2s, and then also with impaired glucose tolerance compared to normal. Questions? Okay, that's the GLP-1s. Let's start talking about insulin. Let's see how far we did. Okay, so I said yesterday a little bit about insulin was first discovered, and the amino acid sequence and how you could get it came out in about 1922, so almost 100 years. And what they did is they extracted it from pig and beef pancreases. So they just churned up the pancreas of those two animals and did an extraction, and then they injected it into people. So the amount of other stuff you got with it was very high, but the people did well. People stopped dying. I told you it was about 18 months was the average life span after a diagnosis of type 1 before 1922. Nowadays, we don't do that anymore because animal source insulins are highly immunogenic. So you lose a lot of the efficacy because the body will produce a lot of antibodies against it and decrease its effectiveness. So nowadays, we use recombinant DNA to produce the insulin. And what we do is we harness the E. coli and yeast. They usually work for free. And we give them the DNA material to make insulin, and they churn it out all day until you kill them. So this shows you, I think this is Eli Lilly. They use the E. coli. I think Sanofi uses yeast cells. So they take the DNA coding for each of the polypeptide sequences, the A chain and the B chain. They have these bacteria produce those. They take them, they distill it off, and they use chromatography to collect them. And then they put them together with those disulfide bridges, and they get insulin that looks pretty close to what human insulin does. Sometimes when you use the term human insulin, people will think that you got it from a human. But when we use the term human insulin, we are just referring to DNA, recombinant DNA products that look like human insulin. So their DNA sequence is the same. Usually their secondary form and their tertiary folding are pretty close to what a human's is. It will look a little bit different. You will have some patients who will develop antibodies against them, but for the most part, it is not clinically significant. So we have human insulins, but we also have what we call analogs. If you look on page 7, they're listed there. So analogs are insulins that we have taken the basic insulin molecule and we have manipulated its amino acid sequence to get it to do something different. Okay. So this shows you some of the substitutions. Sometimes we'll hang like with Humalog, this is insulin Lispro right here. We took a lysine and a proline and we just flipped them. And what does that do? It makes it be absorbed faster. That's all they did. With glargine, they added some amino acids, and they got that drug to precipitate out at a different pH, and when it precipitates out, it forms a depot, and then it absorbs over a 24-hour period. So it's soluble at a pH of 4. You put it into tissues that are a pH of 7, and it forms these little hexamers, and they just precipitate out into the tissue fluid, and then slowly they get absorbed. With Dedimer, they put a fatty acid chain on it. Just makes it slower to be absorbed. Okay. So the analogs have all been manipulated to change usually speed of onset. Now, why would we do that? So when we're giving somebody insulin, we are trying to replicate as close as we can what normally would happen. So if we're talking about a type 2, what has changed in their insulin response, in their phases? What's different compared to a normal person? Okay, basal, what about basal? In type 1, it's gone. Type 2, it's usually, it can be elevated early on, it can be low later on. So the amount of insulin they put out per hour is different. What about the phase 1? What happens to phase 1 in a type 2? It goes away. So, and that was usually the quick onset, right? Phase 1 starts right after glucose starts rising. So we use bolus insulins, quick-acting, rapid-acting insulins to replace that phase. Okay. Phase 2 will also be covered by a bolus because usually we can get it in the system fast, it will be absorbed fast, and then we can make it so that it'll last for about 3 to 5 hours. And then we give insulins like glargine to provide that basal. So we try to replicate what the body normally does with the insulin types that we use. So that's how the analogs have made a great strides in helping us replicate what normally would have happened. So that's why we spend so much time talking about how insulin usually is released, because that's what we're going to try to replicate. Okay? The only difference is where does insulin get secreted out of the pancreas? Portal vein. And where are we putting insulin usually? Subcutaneous space. So there's always a difference. But it's close. Okay. So it is very important that you can tell me which insulin belongs and what type of insulin it is, okay? I don't care, analog and human insulin, not so much. We mostly use analogs anymore. But you need to know speed of onset and whether they're a bolus or a basal. So there is an ultra-fast rapid acting. This is Fiasp. It's brand new, just came out on the market. It's rapid, it's ultra rapid because it gets into, when you inject it, it gets into the bloodstream like in 2 minutes. Okay. The rapid acting get in about 10 to 15. So rapid acting would be Humalog, Novolog, Apidra. You've probably run into these at Good Shepherd if you have had a diabetic. There's a new one called Admelog that's just come out. It's called a follow-on, or it's a biosimilar. So it's similar to Humalog, to the insulin Lispro, but it's probably going to run cheaper. I don't know what its cost is compared to, but it probably is a little bit cheaper. So these are all the rapid. These would be bolus insulins. You would always give these before a meal. In one ringer. If they're wearing a pump, most of these will go in a pump. These rapid acting in pumps, insulin pumps. So they may give them at times that isn't when they're eating, but they're correcting a high. But for the most part, what you're going to be doing is you would use these to cover a meal. Okay? The long acting. Lantus, Basal-Gar is a, Basal-Gar is a, it's a Me Too Lantus. Toujeo is also insulin glargine, it's just a more concentrated form. Levemir is different. So these three, insulin glargine and insulin detamir, are all basal insulins. You have to be able to tell me this. I can't tell you how many times I will ask you. Or you'll have a test question. You have to know them. Next page. Time course of activity. You must know. You cannot prescribe these things unless you know these. You got to know when they're likely to onset, when they're likely to peak, and how long they're going to last. Their onset is more going to dictate is, do I use them before a meal, do I use them as basal? When they peak is usually going to be when they're most likely to have a hypoglycemia. So when the patient comes in and they're telling you, I'm getting low every day about 2 o'clock in the afternoon, the first thing you do is look back as to what insulins have they taken and what time. And then you can tell which one, when was a peak insulin activity, and that's the insulin you have to make adjustments. So rapid acting, Humalog, Novolog, Apidra, short acting. So regular is considered a short acting because it's delayed in onset and it lasts a lot longer than rapid acting. Intermediate is NPH. It's usually used as a basal insulin, usually dosed twice a day, but it's a little unique. Long acting are Lantus and Levemir. And then within the last year or two, a very ultra-long-acting insulin, Tresiba, came out. NPH, Lantus, Levemir, Tresiba are all basal insulins. You should have a very good idea of onset. Most of the rapid-acting onsets are going to be about 15 to 30 minutes. So guess what? We tell patients, take this about 15 minutes before you eat. Fiasp is the only different one. We can tell them you can take it when you start to eating, or you can even take it once you have eaten, as long as 20 minutes after you eat. It's a little bit different because it's so rapid. Peak effect will tell you about hypoglycemia. Duration of effect is how often do you have to give it. I'm going to 3 and then I'll let you go. Okay, question? You have to memorize those and you have to be conversant with them. Page 9. Bolus insulins, always given before a meal. They replace phase 1 and phase 2 secretion. Look at this picture. I would study that one just to kind of get it in your brain. So you see there with Lispro, blue lysine, Azapidra, and Aspart. Okay. Those are your bolus insulins. Look how fast, if you eat at time 0 and you take them, look how fast they get into your system. Okay. You want, as they're eating and their blood sugar is rising, you want that insulin right there along with it, because if they're perfectly matched, it will blunt how high that blood sugar goes and then get it back, starting it back down to baseline normal again. Okay. If you wait too long, then the horse gets out of the barn and you're chasing it all the time. Okay? So the sugar keeps going up and the insulin is trying its best to get on top of it. Okay. You see regular. Regular's peak is delayed and it's a whole lot longer. It's that blue line. You can use that to your advantage. Regular is very cheap. It's $25 a vial. Lantus is about $260 a vial. NPH is a intermediate. It is a basal insulin, but look at it. It's different. It has a peak to it, which is somewhat sustained, and then it tails off. We can use that to our advantage in people who don't want to take a lot of insulin injections, because you can have them take it at breakfast. They'll get a peak around lunch. It won't be great, but it's enough that it may cover their lunch meal, and it'll last until supper when we have them take it again. Detamir, it is a basal, but it is how long it lasts is dose dependent. The more you give, the longer it lasts. The less you give, the shorter it acts. You'll see it has somewhat of a rise and then it falls off. Glargine is beautiful because it is pretty much a sustained IV-like profile. Know these. You guys look like you're falling asleep. So this is important stuff right here. Mark it. Get it in your brain. It will so help you. If you know these, when a patient comes in and starts talking to you, you'll know exactly which insulin is causing the problem. If you're looking at their blood sugars and they're running 300 or 400 at a certain time of the day, then you know which insulin you have to modify, or you know which insulin they're not taking. You know, you can learn how to use the orals, and you can learn how to use basal insulin, but when you start learning how to use insulin, you really are going to have to work with somebody who knows it and has experience. Mostly with insulin, it takes experience. It takes this basic knowledge, and it takes follow-up. Okay? So in our clinic, when we started somebody on insulin, I called them the next day. Sometimes I'd call them that night if they were that fearful about starting. And then I would follow up with them in 3 days. And then I would follow up with them in 7 days. So I saw people with insulin very frequently. There is no way a provider can do that. So you got to have people who either your nurse is trained, or you've got an educator that you work with that can work with them if you want to get them to goal, especially when you've got people who are very high to start with. Okay, the basal insulins, when are they injected? Usually once or twice a day, usually without regard to a meal. So it really doesn't matter when you inject Lantus. You just need to be consistent about it. Same with Tresiba. You can inject it any time, but you just have to be consistent. Here's Tresiba. It's like Lantus. It's very flat. That's good. That's what you want out of them. That's why I love Lantus and I like Tresiba, because they're just flat. Don't have any little bumps usually that you have to worry about. So NPH, usually we do it twice a day. We can sometimes just give it at bedtime and do it overnight. Why would we do that? We can suppress that glucose, especially if people are having high blood sugars first thing in the morning. We can give them some NPH at night. It will suppress the hepatic glucose output. Also, what the kidney is adding to glucose levels, and we can get you always want a good fasting blood sugar, because that's what you build off for the rest of the day. If you start off high, it is hard to get down. So if you can start off in range, and our preprandial blood glucose goal is what? 80 to 130. Preprandial. Remember? What's our postprandial goal? That's the endocrinologist wanted the ADA's goal, 180. So less than 180 to 140, 2 hours, 1 to 2 hours after they eat. When are these injected? Okay, boluses, usually the rapid acting are 15 minutes before they eat. So we tell them, as you're planning your meal, then about 15 minutes before you eat, that's when you want them to give it. Okay. Any longer than that, and if they're pretty close to goal, they'll go too low before they can eat. Because it's rapid enough, it'll just drive it on down. Okay. So about 15 minutes is good. For people who are very tightly controlled, they could take it right when they eat. But most of the time, it's within 15 minutes. Regular, we may have them take it 30 minutes because it has such a delayed onset. Basal insulins, again, with basal insulins, it's consistency of when you take it. If patients are taking basal at all over the place inconsistently, it becomes really difficult to figure out what drug is it, when is insulin active, are they stacking insulins on top of each other, and you can't figure out what is causing the highs or the lows. Where are they injected? So one of the things we teach patients is, where do you inject your insulin? For most type 2s, I like the stomach because it's big in most people, and there is enough space for them to rotate. The thickness of the skin is fairly uniform over the abdomen, so that's what I like. But you can see that there's many different places. The thighs. The only thing about the thighs is just don't go and exercise after you do that. The arms, I think, are hard to get to. I had patients who could do it, but I think they're really contortionist if they can do it. But if you've got somebody giving you insulin, then the arms are good, the back of the hips, and again, the abdomen. We always talk to patients about rotate sites, move it around. I usually tell patients, imagine the face of a clock, and just keep moving your insulin around the face of that clock. Stay away from scars, don't inject it into your belly button. But keep moving it around.
How many times has that happened?
Enough that I'm telling you. Okay. All right, so here you can see, this is someone who is injected into the same spot over and over again. So two things can occur. This can happen with Humalog. It is an immunologic response, and so they've made antibodies against that insulin, and the fat has gone away. So this is a lipodystrophy that can happen. So you can get a lipoatrophy, or you can get lipohypertrophy. Now, since insulin is an anabolic hormone, if you continue to inject into the same place, usually what you get is you get a nice little fat pad. And here's a picture of one. If they rotate sites, that eventually will go away. Usually what we'll do with those lipoatrophies is we will get a different type of insulin and we will inject into it so that they'll build up that pad. But it'll take several weeks to months to do that. Okay? So those are the different dystrophies that you can get. That's why you want them to rotate sites. do the rest of this tomorrow. Okay, all right, we'll pick this up when we talk about type 1. I'll see you at 8:30 in the morning. We'll talk about pathophys type 1. And then we'll do insulin therapy for type 1s. The glucometers I moved to tomorrow. I don't have that updated. I've got the stuff from last year, but I really need to look what's come out this year and update it. So I think that's it. All right, see you.
About it. I'll do it.
I started it, but it's
Oh, yeah, I didn't hear you, so I have to do it, and I was really helpful to her.
it saved a lot of time.